Welcome, this is Dr. Jason Linder, and I'm going to be presenting on my dissertation study. My main research question was, how do licensed EFT and EMDR therapists integrate both models in couple therapy? My inclusion criteria for participants were being licensed as a therapist or clinician in the US, seeing couples in their practice, using EMDR for trauma, using EFT with couples, integrating both models in couple therapy, and being well trained in both. More specific inclusion criteria is specified on the slides. Methodology. Thematic analysis is useful for highlighting commonalities in qualitative data regarding patterns across participants' responses. EMDR and EFT integration has been reported as a very important topic among clinicians, but under-researched. So, data collection and analysis, I used social media. I contacted ICEFT and EMDRIA, the international organizations or associations for each model. Snowball sampling as well. I conducted 13 interviews lasting 60 minutes each. Participants received a gift card. Transcriptions were done on rev.com. Interviews were audio recorded. Qualitative analysis software was MaxQDA, and only the codes in the data with 7+ mentions became a theme or sub-theme, and that 7 means that at least 7 of the 13 participants, which is more than half, endorsed that particular theme or sub-theme. Themes are presented, all 7, in order of frequency and the number of participants who endorsed them. Earlier themes were more frequent and salient in the data. All 7 themes, here you go. EFT and EMDR complement each other well. 7 sub-themes. Theme number 2, integration benefits couples. 10 sub-themes. Theme number 3, key integration variables and choice points. 6 sub-themes as well. Theme number 4, risks of integration. 6 sub-themes. And theme number 5, integrating other models besides EFT and EMDR like IFS, AEDP, or Gottman. Theme number 6, integrating EMDR at any stage of EFT, and theme number 7, integration as the rule, as the exception, not the rule, in most participants' experimentation with integration. Let's talk about an example quote from a participant in theme number 1, not sub-theme. EFT and EMDR complement each other well. The information about what's going on in the brain and everything related to that with EMDR and the emotional component of EFT is this perfect dance. This particular theme across all sub-themes was mentioned 87 times across every participant. Theme number 1, here are the sub-themes in more detail briefly. EMDR helps couples self-regulate in EFT, couple therapy. The adaptive information processing paradigm and attachment theory are complementary. Sub-theme number 2. Number 3, both models here heal attachment trauma. Number 4, both are theoretically and practically similar. Number 5, trauma and its healing are relational. Number 6, both models explore negative beliefs. Number 7, integration is the next step in the research and practice of the clinical evolution of both models. Let's briefly share an example from this sub-theme that both heal attachment trauma, mentioned 44 times across 8 out of the 13 participants. Many of the traumas addressed with EMDR happened within the family. So trauma, I mean, the definition of trauma is an attachment injury. So moving on for time, let's go into theme number 2, example quote of integration benefits couples. Integration has been overwhelmingly or predominantly, let's say, effective and for some transformational. This theme was mentioned 77 times across 13 participants, so every participant. Theme number 2, let's go over these 10 sub-themes, bear with me. Integrating EMDR gets to the root of the EFT negative cycle, which is the predictable pattern of distress that couples get into that EFT works to dismantle. Number 2, integrating both models helps clients develop insight into their problem, their traumas, and their solutions and healing. Number 3, integrating EMDR helps EFT work better. Number 4, floating back to earlier traumatic memories in EMDR helps make progress in the EFT negative cycle that I specified above. The sub-theme number 5, integrating EMDR shows how the past affects the present, giving clients more insight. Number 6, Integrating EMDR helps fill the trauma gap of EFT. Many EFT-trained clinicians reported that their training in EFT only didn't equip them well enough to treat trauma. Number 7, the advantage of knowing both models well clinically. Number 8, conjoint EMDR. That is when the partner observes each other receiving EMDR, helps couples develop intimacy. Subtheme number 9, integrating EMDR led to big change in EFT couple therapy. And number 10, lastly, relationalizing EMDR, that is using it outside of its traditional context and in individual therapy only, maximizes its effectiveness. Let's skip to theme number 3 for time. Here are the 6 sub-themes. Participants only reported integrating when the relationship between their clinical couple was reported or assessed as safer. Number 2, severity of the participants' trauma. The participants' couples' trauma dictated whether or not they integrated other integration choices. Number 3, integration is based on collaboration with that couple. Number 4, psychoeducation is vital in integration. Number 5, individual EMDR sessions must serve the couple when the clinician uses them, and they are to be used sparingly as well. Number 6, individual assessment before conjoint EMDR given. Theme number 4, the risks of integration. Integration was found to be risky. Subtheme 1. Number 2, going rogue was reported across participants when they discussed their integration experiences. Number 3, integration is quite complex clinically. Number 4, integration is not always positive. Number 5, potential rigidity of the model developers according to participants. Number 6, the potential contraindications of being both therapists and clients live, their couple for EFT, and their individual when using interventions from EMDR. Briefly into theme 5, participants reported to prioritize helping their clients couples over loyalty to a specific model. That's more my assessment. Participants believe in working integratively and integrating IFS, Gottman, ADP, and other models into their couple work. As one participant said, no model is fully sufficient in every clinical context in couple therapy. Briefly moving on to theme 6, integrating EMDR at any stage of EFT. EMDR can be integrated across any of the 9 steps inside the 3 stages of EFT. Some participants noted that conjoint EMDR can help couples de-escalate in stage 1 by increasing empathy and compassion, while others reported that it's safer to do conjoint EMDR only in stage 2 of EFT after more emotional safety between partners is established. This theme was mentioned 19 times across 8 participants. There's more information on the slide if you are interested. Theme number 7, lastly, overall integrating both models occurred less frequently than not in their practice because of the risks and the conditions necessary for successful integration, reportedly. All participants, or at least 7 of them at least, reported using conjoint EMDR. Sample quote, honestly, it's rare, probably less than 25% of the couples that I can integrate EMDR with. Unfortunately, because of readiness, because of safety, because of partners being maybe 1 foot out or not being able to be responsive, or there's not that personal accountability. Okay, discussion. Many of the findings were consistent with the literature. The literature and the present study suggests that EFT and EMDR can work well together in multiple ways and for multiple reasons, but the present study mainly adds more detail about how they work well together, why and how it benefits couples, and navigating choices and the risks of integration. This study uniquely suggests EMDR may compensate for a potential trauma gap reportedly in the EFT training. Integrating models may be the clinical evolution of both, as was one of these sub-themes reported already, and integrating EMDR was specifically reported to improve the effectiveness and speed of EFT. Clinical implications: practitioners must balance individual and systemic factors in couple work. EFT or EMDR alone may be insufficient in treating the vast array of clinical and relational challenges clients bring. EFT seems to best address the relational and the interpersonal, whereas EMDR seems to best address, according to participants, the intrapsychic elements such as beliefs, emotions, sensations, and the neurobiological storage of trauma. EMDR and other traditional individual therapies may overemphasize self-soothing at the expense of relational co-burdening, whereas from an EFT perspective, there's an overemphasis on co-burdening or turning to one's partner instead of training partners to self-soothe. So as we can see, they may balance each other very, very well. Limitations of the study, briefly, it does not incorporate client perspectives, which makes us unable to ascertain clinical outcomes and if what my participant therapists were doing was actually effective with their couples. Social justice element, most participants in the study were white, despite me attempting to recruit as diverse a sample as possible. Do only white therapists have the economic and the logistical wherewithal to be trained sufficiently in both models? That could be a future research question. The present study's format may have also inadvertently privileged the relationship status quo, possibly reflecting a bias for the cisgender, heterosexual, and monogamous client couples that most reported to be treating. So more research is needed with diverse clients and therapists. Lastly, directions for future research, then I'm going to have to wrap up. Aside from more diverse clients and therapists, helping establish measures or scales to appraise couple readiness for integrating EMDR to determine a trauma severity regarding the subtheme already presented, or a threshold to engage effectively in conjoint EMDR, or at least a cost-benefit analysis, specifying indicators and contraindicators for effective EMDR EFT integration, and longitudinal outcome efficacy with studies with client data and perspectives, creating a clinical choice map or a manual for how to integrate models. There we go. Thank you so much, and I hope you enjoy the rest of the conference.